This is a talk that I gave for a North Carolina, South Carolina otolaryngology meeting last summer. And believe it or not, Howard Farrell, I don't know if you guys know him, but he was the first otolaryngology resident here at the University of Kentucky. He took Q1 call. He asked me to come and give this talk. So this is just part of the talk originally. This is for the people in the conference. Let's see. You know, the obligatory UK and bourbon pictures. Okay. So when the textbook yields no answer, again, the history about this is, I feel like over the past 7 to 8 years of my practice, I've seen a lot of just strange and unusual things that just kind of, you know, I couldn't find the answer in a textbook. Just kind of made me scratch my head and, you know, kind of had to think through these things. So I just put them together into a compilation of things with some pictures and video and fun stuff like that. All right, so yep, standard disclosures. Okay, so our first one is an infant with a massive congenital macroglossia. This is actually a case that we had when I was in fellowship at the University of Alabama in Birmingham. And this young boy, the first time we heard about this was my fellowship director, Brian Whitrack, got an email from a colleague who was doing a mission trip or something like that in Haiti. And they found this kid who basically his mother had given him up for adoption. He was 8 months old at the time. He had had this enlarging tongue, and the only way they were able to feed this kid was to take a little syringe and kind of squish his tongue down kind of at the roof of his mouth and try to introduce some milk or some formula or something that way for him to be able to eat. And you know, this was getting worse. He was getting progressive respiratory difficulty, but thankfully, you know, with these babies, as we know, they're obligate nasal breathers, so it doesn't matter if their mouth is obstructed like this, as long as they're breathing through their nose, they actually do okay. But of course, eating was a very difficult thing. So basically, they made the connection through our hospital at the University of Alabama, and they let us basically bring this kid over and do this as a pro bono case. And this missionary here, Julie, was able to bring this kid over, and we were able to bring this kid in and address him. So anyway, that's what he looked like when he first came to us. You can see that the tongue, you know, has been exposed to the air. It's kind of dried out. It's very chapped, peeling, that kind of stuff. Now, I don't know if any of you guys have been to Haiti, but has anyone been to Haiti?
I've been to Haiti.
Who's that?
Kate.
Kate, okay. Does this look like a familiar scene to you?
Very familiar.
Yeah, so I had the opportunity to go when I was a fourth-year resident in medical school, not medical, sorry, fourth-year resident, and I went with one of my mentor, who was a peds ENT, and we went and we worked at this orphanage, and you know, this kind of one day we went out just kind of walking the streets, and this is what you see. It's you know, there's kind of trash piled upon trash, ramshackle, you know, things put together that people live in. Interestingly enough, and this was in 2010 actually, so 10 years ago. Interestingly enough, you know, people come out of these huts like this and they actually have cell phones, which was kind of interesting at the time. This was the only green patch of land that I saw there, so I want to take a picture of it. Let's see. But you know, the kids there, they're so sweet, loving. They just kind of ran up to us every time we, you know, went out, and they wanted to see what we were up to, and it was just neat to get a chance to talk to them and address any health issues that they had and concerns. We kind of ran a clinic for them. Me previously when I was beardless, just hanging out with kids at the orphanage. This is a tap. This is their kind of the public mode of transportation. They call it a tap because you jump on this thing and then you tap on the top of it a couple of times, and that's how they know to stop, so you can get off. But they decorated them up really, you know, really cool. This is a picture that I took of the presidential palace in Haiti on January 6, 2010. This is when I was there. And then 4 days after I left, this is me leaving. This is a picture I pulled from the internet. Well, it was 2 days after I left, I guess. That earthquake had happened. So I actually, the day after I got back is when the earthquake happened there, which was kind of interesting. But anyway, back to our gentleman here, Del Cardo. Sweet kid. We got a CT scan. And as you can see, he had this kind of bilobulated, cystic appearing mass that basically took up his tongue and the base of the tongue, and he kind of had some pressure of the back of the tongue, just expanding towards his airway there, which was kind of contributing to his progressive airway difficulty. This is a sagittal view of the same thing. And yeah, you know, you can see his airway is starting to get fairly compromised there. So, you know, congenital macroglossia, what is this? You know, what do the textbooks say? Well, found some things about pseudomacroglossia. Certainly there are genetic syndromes can be associated with macroglossia. We'll go over some of those. Metabolic derangements that cause deposition into the tongue that can lead to macroglossia. Certainly different anatomic things can occur. Tumors, lymphatic malformations, vascular malformations. You know, these are the things that are going on in our mind. Of course, one of the things you want to think about with congenital macroglossia, Beckwith-Wiedemann, again, a very common finding that you see with that, but of course, not necessarily to the degree that we're seeing here. Mucopolysaccharidosis, you can get deposition of different metabolic components into the tongue that can lead to macroglossia. Neurofibromatosis, we actually had a kid here that had an 11 centimeter mass of the tongue that was a neurofibroma that we had to take out. I should include her pictures, but I haven't. This is just a random picture of someone with neurofibromatosis, but you can definitely see macroglossia there. You can get vascular malformations. This was a child that we saw with vascular malformations of the tongue that we had to end up reducing. Congenital ranula, these have been reported. This is an exit procedure that was performed. There's a picture from a textbook. I can't remember which one actually right now, but you can see how they're doing this exit procedure and decompressing this congenital ranula. Now there's several ways to address the reduction of the tongue for macroglossia. You can see over here on the left side of the screen several methods to debulk and reapproximate the tongue. You know, this can be used for you know, macroglossia causing sleep apnea or dysphagia issues, whatever the case may be. But in our case, getting back to us, this was this picture. I like to think of the joke of this joke that I came up with was how many how many anesthesia providers does it take to intubate a baby with macroglossia? And the answer is 4. So 1, 2, 3, 4. So, you know, the thought was, how are we going to secure the airway of this kid? Well, what we had a fiber optic set up. We had a glide scope set up. You know, we really couldn't put an oral airway here in this kid. But what we did was just kind of masked him down with his nose, kept him spontaneously breathing, gave him a jaw lift and a nasal airway, and we were able to maintain the airway then. And we had our flexible stuff available, but in this case, we were able just to do a DL with a Mac blade actually, and it just pushed the tongue right out of the way, and we're able to get a fairly decent view. So we got the kid intubated here, and you know, our first goal was to get this kid trached and G-tube placed, because again, we didn't know what this was. We didn't know if this was going to recur. We wanted to kind of give this kid a secure airway, get him worked up, get the failure, address his failure to thrive, and just kind of get some diagnostic assessment here. So once we trached him, we stuck a needle into this thing, and we drew off about 60 cc's or more. You can kind of see in this little tubing of this kind of yellowish type of fluid that we just sucked off of this thing, and it just turned into this big deflated balloon within his mouth. Of course, you know, we wanted to trach him, so we didn't want, you know, all this deflated tongue just to flop back into his airway and obstruct his airway. So that was kind of the reason we ended up traching him. But we were able to secure his airway. Ped surgery did a G-tube. We sent this material off for cytology, working with our pathologist there to see what this would be. So after 2 weeks, after giving him the trach and the G-tube, we worked with speech therapy and got him optimized for swallowing, and because his tongue actually, you'll see in another picture, decompressed quite a bit. Optimize his nutrition. Of course, we're looking at this aspirate here, now analyzing that, but it turned out he did have some reaccumulation of fluid, and we took him back to the OR for a definitive management of this. One thing I do want to point out, and I think we'll get to it in another picture, but you know, this kid's jaw, his mandible, was remodeled by this thing. So he just kind of had this severe open bite, couldn't close his mouth, just because his jaw had been remodeled that way. But again, this is after we'd given him some TLC. You can see that he did fill up a little bit more after we decompressed him, but his tongue is starting to look a little bit more normal, at least for the anterior 2/3. He's got some swelling here, the floor mouth and the ventral surface. Basically opened up the tongue, found this large cystic-like structure. We took this out, we took out the sublingual gland, and we're able to preserve the submandibular duct and hypoglossal nerve and lingual nerves. You can kind of see those splayed out there in the picture. Closed them up, and you know, his tongue's starting to look pretty normal at this point. Put a drain in there just because there was a huge space in his submandibular space there, and watched him another 2 weeks. Took his drain out, kept working with speech and swallowing. He began able to tolerate oral feeding, and we were eventually able to decannulate him. And this is his picture afterwards, pretty close to where he was ready to go home. As you can see, you know, here his tongue looks fairly normal, but again, he's got this kind of slack-jawed appearance, where his mandible had been remodeled. He really couldn't close his mouth, but he was breathing much better. He was able to tolerate oral feeds, and he was gaining weight, and we felt that he was okay to go home. And we didn't send him back to Haiti though, but they kind of stayed in town with the missionary, and basically he was put up for adoption. The missionaries actually ended up adopting him, and we got a CT scan afterwards just to check for any residual, because there was a report of some further swelling at one point in time. But you can see here that the appearance of his tongue has gone back to essentially normal, much better airway. So looking back at his pathology, this was a smear of the aspirate there, and there's some epithelial cells. We got some lymphatic tissue here as part of the floor mouth specimen. This was the final specimen. It was 6 by 2.5 by 2 centimeters. You can see it's this large cystic structure here. Looking at the epithelial lining of this thing, we've got some squamous epithelium here. We've got some respiratory epithelium, and some salivary tissue. So by now the diagnosis of this is obvious, right? Everybody knows what this is. Any thoughts on what this could be? Nothing? Crickets? Mark Fritz knows what it is. No, he doesn't. All right. Okay. So it's a foregut duplication cyst. Has anybody heard of these?
Ooh.
Very obvious.
Has anyone ever heard of this? I mean, just curious, because I had never.
I've heard of it. I've never seen it.
You never saw it. Okay. So yeah, foregut duplication.
I thought it was gonna be a lymphatic malformation.
Yeah, I mean that was kind of in our differential too, but looking at the different epithelial linings, that's what they said this was. Our pathologist there was actually very, very good. We had conferences with them on a monthly basis, which is pretty unique experience there. But yeah, these are lingual chorostomas. They're pretty rare. They can form usually along the midline. They can actually form in the gut as well. But most of the time, if they're going to be found, they're reported in the anterior tongue, and they're lined by epithelial cells that have all sorts of characteristics of the upper aerodigestive tract. So you've got squamous tissue, you've got the foregut tissue lining it, you've got epithelium or respiratory epithelium, those types of things. So again, they can be confused with dermoids, hemangiomas, linguothyroid remnants, granulas, or lymphatic malformations. But yeah, this was kind of a diagnostic conundrum, but we're able to take care of this. The theory about how these form is that there might be some epithelial inclusions trapped during the fusion of these primordial forming tissues, and somehow form from that. This was a picture of me and him right before he left the hospital, and I've just got one of the cool things about him is he's kept in contact, or his adoptive parents kept in contact with my fellowship director, and he updates me every year how he's doing. And one of our big concerns was what's going to happen with his jaw. And we talked with the oral surgeons, and their thought was, as he starts to eat and do things normally, as his kind of muscles develop there, kind of in a more normal with normal stresses and things like that on the musculature and the bony structures, that things would just remodel. And I've got kind of a compilation of pictures over the past 7 or 8 years or so, just to show how that has taken place, which is really quite remarkable. And he's kind of a handsome dude. So this is him going home. This is him on his second birthday. You can see he still has a little bit of an open mouth posture, but this is him. You know, his teeth have come in. He's just a normal, 2-3-year-old kid goofing off, and here he is. His jaw is pretty much remodeled. He's closing his mouth. He's got a good set of teeth in there, as you can see. Just a handsome young man there, and he's doing really well. So it's just a remarkable story, remarkable thing that I was had the privilege to be involved in. So let's see. Any questions about that case? All right, so second one is a baby born with this nasal deformity, 41 and 5-week child, born at an outside hospital here in Kentucky. Had a lot of stutter and difficulty breathing, so they sent the baby over to our NICU, presented with what you see for congenital neonatal airway obstruction, the classic cyclical cyanosis, this paradoxical respiratory distress, which of course is, since babies are obligate nasal breathers, they, when they're crying, they're breathing. When they're not crying and their mouths are closed, they can struggle. They can have periods of apnea. Certainly it's very difficult for them to feed, coordinate that suck, swallow, breathe coordination. But this is a picture of the baby. We've got kind of a up close picture of the left nostril. There's a kind of a malformation there of the ala, and just a very pinpoint hole there for the nostril. On the right hand side, you can see there's some tissue there on the medial side that is obstructing kind of where the septum would be, blocking probably about 90+% of the airway. We've just got a very small airway there on that side. This is a picture down the line, but he's got some, very narrowed choana on the back, on that side, on the left. This is our CT scan that we obtained. So first, let me just throw this out there, because I do want to make this a little bit of an interactive kind of learning thing. When you've got a baby like this who is having this paradoxical respiratory distress, what are ways that you can manage this baby to maintain the airway? Just gonna throw it out there for questions, and we won't move on until I get at least 3 or 4 good answers.
Depends on the patency of that right side, but you could potentially get a nasopharyngeal airway in there, and then you could also consider a McGovern nipple.
Yep. Everybody familiar with what a McGovern nipple is? Anybody not know what it is? Everybody knows. All right. Yeah, McGovern nipple. What else? What if you can't get a nasal airway in? Or if the baby keeps spitting out the McGovern nipple? Nothing?
I mean, trach.
You do that right away?
No, but it's just
Yeah. Right? Yeah. I mean,
Potentially depends on, you could maybe get some non-invasive positive pressure
yeah.
ventilation through, and if that fails, then oral intubation.
Yep.
Until you come up with a definitive plan.
Yep. Good. And then, yeah, ultimately, if you can't, if these babies can't breathe through the nose, as Dr. Mullen, I believe, recognized his voice, you'd have to trach these babies. So that was kind of our, pathway in this child. How can we, first, how can we initially stabilize? We basically stabilize this baby with an oral airway. Did fine. Got a CT scan to see what's going on. So here on the right side, you can see that the nasal airway is pretty patent posteriorly. But when you look here in the front, the septum is just kicked way over here to the right. There's this wonky curve that's just narrowing the airway anteriorly. We don't really see much of a piriform aperture stenosis. That really doesn't appear to be an issue here. You look at the left side though, and there's no airway. It's kind of a bony obstruction, and there's just other than that little pinpoint area you see, it's just that there's no real nasal airway there. So we got an MRI just to make sure we weren't dealing with any sort of encephalocele or meningocele brain hanging down into the nose or anything like that would obstruct or impede anything that we were would try to do to give this baby an airway. So again, what in the world is this? How do we manage it? Do we just observe? The baby's not able to do well without some sort of oral airway, definitely not feeding well, so that's not a good long-term solution. As Dr. Mullen mentioned, we could trach this baby, and I think that would be the gold standard. What you could do to, if you didn't have any other options, or if all other options fail, that's what you could do. Attempt some kind of repair. That was another option that we had. But again, what is this thing? Is this some sort of facial clefting? These are the Tessier classifications of facial clefting. We were thinking, well, is this some sort of facial clefting thing? You look at the nasal development embryologically, as far as the way things form, you've got these maxillary prominences here. You've got the lateral nasal prominence and the medial nasal prominence that kind of form out laterally, and these things migrate in medially, usually about 8 weeks of age, and form. And by 10 weeks of age, you've got formation of the philtrum and the lip there and the nasal ala. So obviously we've got some sort of disruption in the process going on here. Again, when you look at the internal nasal development, you've got this oral nasal membrane that kind of starts to disintegrate, break down as the nasal pit forms, and you get this the medial nasal prominent kind of forms your primary palate, and then you get secondary palate formation, and certainly something has gone on that left side of the nose to where the nasal cavity is not forming. So obviously something going on there. I do have a thought for what this could be. I'm still not entirely sure, but does anyone, before we kind of get into how we address this, does anyone think, or can anyone think of any other sort of congenital nasal malformations that this might be? or be a variant of? Okay, good. I wasn't the only one stumped. I've had a couple of years to think about it, though. Anybody?
Almost looks like a, well, you have arrhynia.
Right.
So, also along the spectrum of piriform aperture stenosis.
Right. Yeah. So I do have another talk, maybe I should have given that one first, but it's another talk on nasal airway, congenital nasal airway and nasal malformations, because for some reason we see a lot of those as well here. In fact, today we've got a piriform aperture stenosis we're going to do later today. So you've got arrhynia, which is pretty rare. You can have polyrhynia, actually, where you can have duplication of the nose. What else? Anyone heard of a proboscis deformity?
No.
No? Okay. So proboscis deformity, you know what? I should probably get a picture of that. Give me just 1 second. I'm going to take a little detour. What are you seeing right now? Are you seeing me?
Yes.
You're seeing me. Okay. So I'm no longer sharing. Okay, let me find this real quick. I'm just going to show you what a proboscis deformity looks like. Can everybody see this?
Yes.
Yeah, so the proboscis deformity is where you have a unilateral, basically failure of the nose to form, and many times you get this proboscis here that forms kind of towards the medial canthus. So my thought on this baby is that this is some sort of, variant or maybe a mild version of a proboscis deformity. After, just research and thinking about this and looking at the literature, that's kind of the best explanation that I have for what was going on here in this case. Anybody seen a proboscis? Probably not. All right. Okay, I'm trying to come back to sharing my other screen. Okay, everyone see the PowerPoint now?
Yes.
Okay, so how did we approach this? So, we decided to try to approach this kind of like we would approach a piriform aperture stenosis, going through this sublabial approach. And, really we knew that we really didn't have much of a chance of getting a left-sided nasal airway established, especially in this neonate. But we saw that the right side looked pretty good, except for just the way things were anteriorly. So our goal in this was to try to give this kid at least one side of the nose to breathe through. Because as you know, the unilateral choanal atresias, those types of things, babies, they can function fairly well with that, and even survive and do fine up until later childhood, where they normally present with a unilateral rhinorrhea for the unilateral choanal atresias. So our goal is to give this kid at least one nasal airway, try to avoid a trach in him. So this is our approach. And let me just show you. So this is how we lifted it up. This is some of the nasal mucosa on the right-hand side. This was that septum that was kicked way over. But because of the malformation of the nose on the other side, basically we weren't too far away from the orbital rim on this side. So here's a video of what we did. Is everyone seeing this?
Yeah.
Okay. It's kind of paused right now. Hopefully it'll pick up, but maybe just can't handle the bandwidth. Well, what we did was the bony septum that was kind of kicking the cartilaginous septum way over to the right. We were able to separate out the cartilaginous septum from the bony part and ended up drilling down. This is very unfortunate that this is moving this slowly. Drilling down the bony part that was kicking the septum way over and obstructing. Let me see if I can advance through here. There we go. Sorry, folks. Anyway, we're able to drill the bony part down and move the septum over to a midline position. And then we're able to get in here and see that things look pretty patent. Now the septum of the cartilage was kind of had this predisposition to want to bend over to the right-hand side. So what we did was drill a couple of holes in the orbital rim on the left-hand side and then put a suture through that and through the septum and then back through the holes in the orbital rim. And then that way we're able to suspend that septum in the front over to the left and give this kid an airway in the front. And I'm really sorry, but this is not liking us. There's some of the suturing going on. Put a stent in here. Took the stent out and you can see, can everyone see this part right here? We've got a much bigger nasal airway here.
Yeah.
So basically we're able to give this kid an airway on the right-hand side. He started drinking, didn't have any apneas, was gaining weight. We were able to discharge him from the NICU, and you know, he's done fairly well. He's now 2 years of age. I took him to the operating room maybe about 6 months ago because he was starting to have a little bit more of some issues, and he actually ended up having some adenoid hypertrophy. So went ahead and took his adenoid down, and that seemed to help him. And he, you know, he's a cute kid. He's doing well. We're looking with plastics to try to do a cosmetic repair, at least of the external portion of his nose when he's, you know, prior to him starting kindergarten. So maybe in the next year or two, trying to do something there. And I'm going to rescan him to see if there's been any sort of development of his nasal cavity on that side, just to see, you know, what the risks and you know, likelihood of us establishing an airway on that side would be. So, you know, he's not done, but we were able to avoid the trach, and he's doing well. Family's happy, and that's kind of one of the important things. All right, questions about that case? Nope. Okay. All right. So everybody sees this palatal mass on this infant.
Yeah.
Okay. So presented to us, a dentist called me, and this is a 10-month-old female that had about a week history of decreased appetite, just kind of fussy, having some blood in the mouth. They saw this kid and saw this mass of the palate that felt hard. It was this bony consistency. They sent the kid to me just by history of, this child. Child had hydrocephalus, had a VP shunt for that, but otherwise was doing fairly well. Prior to this, afebrile, didn't seem like an acute infectious process. So what do you guys think? This is what I thought was, what did the textbooks say? Was this some sort of weird torus? Is this kid developing an osteoma? We're thinking about fibrous dysplasia, some sort of bone cyst. Is this some sort of weird sinusitis complication with erosion, some sort of vasculitis, where the mucosa has just been denuded there, the palate? Is this some sort of invasive infection going on? So got a CT scan to see what was going on. Folks in the ER had actually ordered this, and you can see that there's this kind of calcified density here in the midline of the palate, with kind of some soft tissue, maybe some air density, some fluid density that's there. Anybody have any thoughts on what? First of all, does anybody remember this kid?
I do, but I don't remember what it was.
Yeah, okay. All right. Well, if there's anybody who doesn't remember this kid, go ahead and just commit yourself to what you think it might be. Let me show you one more video. What you think? Anybody want to offer anything else other than what we ran through on the differential?
Can we see the differential again?
Sure.
This is kind of broad, but minor salivary gland origin.
Yep. Okay. That's a good thought.
Yeah, I was gonna say, looking at the CT scan, it doesn't really look like it's bony because it seems really separated from the bony hard palate.
Mm-hmm.
Like it doesn't seem erosive or
Right.
coming from that. So something mucosal perhaps with overlying ossification.
Right. Right. Okay.
OKC.
OKC. Okay. Odontogenic keratocyst.
Yep.
Okay. Good. All right. Everybody stumped?
Thoroughly.
Biopsy.
Biopsy. All right. So I saw this kid in the office, after they'd done the ER thing and all that kind of stuff. Took a look. One more time. Suspense is killing everybody. I took it out in the office.
Bold.
What's that?
Bold.
I thought he said mold.
I like that mold too. Anybody know what this is?
that an acorn shell?
It's a pistachio shell.
Ha!
So, apparently, so what I ended up doing was I saw this kid in the office. Mom was holding the kid, kind of in her lap, with kid's head on her knees. I kind of got in there with my headlight, a couple tongue depressors, and I was trying to get a good oral cavity exam, because that's how I like to get a really good oral cavity exam in that position. It's a good way to assess the palate, especially if you're looking at cleft palates or things like that. But just got in there and started feeling this thing, and I kind of pushed on it. Of course, the kid's not happy, but then I kind of got a little bit of a movement out of it. And I thought, no way. So I just kind of moved it and just popped it right on out. And lo and behold, it was a pistachio shell. And Mom said, oh yeah, we were eating pistachio shells a couple weeks ago, or they weren't eating shells rather, but they were eating pistachios a couple weeks ago. And, there was some on the floor. I thought I'd cleaned them all up. Apparently this kid was, crawling around, found a lonely pistachio shell under the couch. And put the pistachio shell in her mouth, and it's just the shape of this thing just perfectly fit in the palate between the alveolar ridges. And my sense is that once this kid got there, she kept sucking on it, maybe to try to get it off, and then that suctioning on it kind of caused it to just suction cup, and then just kind of wedge in between the alveolar ridge. Is just this perfect fit. And it just kind of stuck there, so that it irritated the mucosa. That's why there's a little bleeding. But yeah, anytime you see this, you should probably think of a foreign body first in a child this age. Believe it or not, we had a very similar situation happen, I think about a year ago. And it was just, actually it's kind of crazy. There are these Facebook mom groups that go out, and someone posted a picture of their kid with this mass in the throat or on the palate. And they said, hey, does anybody know what this is? Does anybody know if we should see a dentist or an ENT? And believe it or not, one of the spouses of one of our ENTs is on the list, or on the group, in the Facebook group, and says, oh, you should go, you should see, ENT at UK, because, they can figure out what it is. And lo and behold, it was some sort of a plastic foreign body that was in a similar shape, just kind of this disc with a little bit of a concavity to it, where it just suctioned right up on the palate in that alveolar ridge. So there you go. Foreign body, pistachio. Okay, how's everybody doing? Maybe one more case. Everybody getting tired of this?
I got one more in me.
Done.
Okay. All right. So, 2-month-old came in to the ER, acute facial paralysis on the right side. In addition, began to be hoarse, started coughing with feeding. On evaluation, baby's got the right facial paralysis. Definitely hoarse. There's a bulging tympanic membrane on the right-hand side. Left side looks fine. Kid's afebrile. And then because of the dysphonia, we scoped the kid, and he has a right vocal cord paresis as well. Oops. Get a CT scan. And we can see that there's some opacification there of the middle ear and the mastoid there on the right-hand side. The left side looks normal. Got an MRI as well, and there's kind of a mixture of some fluid density and then some enhancing tissue there at the skull base, kind of near the jugular foramen, also within the middle ear space. So what do we think this is? You know, first thought, you know, is this some sort of complicated mastoiditis? Because we have seen those, or complicated otitis media, where there's acute infection associated with facial paralysis. Of course, you know, the vocal paresis was a little bit unusual for that presentation. You know, is there some sort of rhabdo or neuroblastoma, you know, one of the small blue cell tumors of childhood? Was this some sort of vascular tumor? You know, paragangliomas can kind of classically present in this way, but very unusual to present in a child of this age. Got some routine labs. Everything was normal as far as a CBC. You know, there wasn't any sort of white count. Didn't look like there was an infectious process. Lumbar puncture was ruled out. You know, we didn't know if there was some sort of meningitis or something strange there. You know, thought maybe this could be a paraganglioma, but we got the urine metanephrines and whatnot, and that was all normal. So ultimately we decided, well, we gotta get in there and see what this thing is. So we took the child to the OR for a biopsy. We performed a mastoidectomy. We had a bunch of purulent tissue that we saw kind of in the lateral mastoid, but then once we got down towards the attic area, we saw this kind of fleshy mass in the epitympanum, raised a tympanomeatal flap as well, and saw this fleshy vascular mass within the middle ear space. And we went ahead and took a biopsy of it and sent it off as a specimen for frozen. And what they told us on the frozen was that it looked like a small blue, round blue cell neoplasm with a rosette pattern. And of course, they told us they needed more tissue. So we took a little bit more, but again, you know, we didn't have the, we weren't really going to go diving into the jugular bulb at this time and see what was going on down there before we had more sense of what this was. Just because, you know, certainly things like lymphomas, you know, it's not going to be a surgical disease and those types of things. So we wanted to kind of await path to see what this was going to be. So, oh, there's the answer. So we actually ended up sending this off for to an outside pathologist. And you can see here, there's, you know, they didn't see any convincing concerns for a vascular neoplasm. You can see this description of the cells that this person is making here. And as far as what they said, they thought it might be an infantile myofibroma. No evidence of malignancy. Has anyone ever heard of an infantile myofibroma? Yeah, it was on your
No, never.
It was on your in-service, right? A couple weeks ago. Very common thing, high yield, right? So yeah, I had never heard of it either. So infantile myofibroma. So now we thought, well, okay, it's not a malignancy, but what in the world, what do we do with this? So infantile myofibroma, described back in the 50s as this juvenile myofibromatosis. It's very rare, benign disease, but it can demonstrate some kind of local rapid growth, which kind of is what we were seeing at this time, which is why the child presented with the acute paralysis and paresis of the vocal cord. Most common presentation of these is in males who are less than 2 years of age. Half or more present at birth. And there seem to be 3 different types of this. There's a solitary form, which is the most common form that's seen in the head and neck. And this is kind of what we determined this child to have. There's a multifocal form where there can be other visceral involvement or multiple types, and that's usually more aggressive. And then there's a multifocal with a visceral involvement. This is generalized form that can be fatal. So thankfully, this kid had only the solitary form. Now, the other thing is, what do we do? How do we treat this thing? You know, you look at the National Organization for Rare Disorders, and this is what they say. They say there are no standardized treatment protocols or guidelines. Due to the rarity of the disease, there are no treatment trials. Treatment trials would be very helpful. Yes, they would. So we've got this kid with this extremely rare disease. No one really knows what to do. So what do we do? See if this will play. So after we kind of decompressed things and got the biopsy, the facial paralysis actually resolved, and the dysphagia actually resolved within a couple of weeks. We got him in for a hearing test. He actually had normal hearing, and he started exhibiting some normal growth and development. So our first thought was, well, you know, this kind of resolved, at least the acute symptoms. Let's just follow this thing. So this kid is at 2 months. You can kind of still see here that there's a little bit of some tumor there. Or that was initially. This is the 4 month. We can still see something here, but he's still kind of not exhibiting any symptoms at this time. This is out at 6 months of age. You know, this thing is not really progressing in any way. Now out here at 9 months of age, there's actually has started to be a little bit of regression of this. And out by 15 months of age, this thing really has, for the most part, gone away. This is at 2 years out, and there's really no residual mass here at this time. So thankfully, in this case, we just followed this thing, and he was fortunate to be one of the ones that they just kind of resolved and involute and didn't progress. And he's doing fantastic. Any thoughts or comments about that? All right, does anybody know what this is? Is Dr. Neff on here?
I think he's in the OR today.
Okay. Well, this is just a gross picture. Every now and then we see some kids.
Does the light help? Or is it too much? Yeah, I think the light makes them fine.
And that's just a pile of lice that we cleaned out of a kid's hair one time. So anyway, sometimes you see that too. All right, well, I think that's been an hour.
Thank you so much. It's a really great talk.
Oh, good. Glad you liked it.
Yeah.
And thank you all the residents who tuned in and all the people from outside institutions. We're just still trialing this. Would you all mind just in the comments, just kind of informally letting me know what institutions you're from, and any comments or suggestions or input, we're open to all.
Dr. Iverson, can we hear your nasal deformity lecture?
I would be very happy to do that. It's one of my favorite things to talk about. You want it right now or just another time?
Probably another time.
Okay, sounds good. All right, very good. All right, thanks everybody.
Yes, thank you so much.
Thank you.
Bye.